Welcome back to the deep dive. Today, we are opening up a really critical and often high-stress topic for any clinician. It's all about managing cultural differences, personal beliefs, and the law all at the same time, especially when safety is on the line. This stuff is the absolute heart of professionalism in the UK, and it's a huge magnet for scenarios in the MSRA, SJT.
Oh, that's so true. These questions, they're not just about ethics, are they? They really test your ability to apply GMC guidance and, frankly, the law when you're under pressure.
Right.
If you can navigate a conflict between a patient's deeply held belief and a vital treatment, you've basically shown you've got the core skills of a safe doctor.
Okay, so let's jump straight in with a scenario that just highlights that tension perfectly. Imagine this. You're reviewing a 75-year-old patient.
Okay.
She needs a hip replacement. It's elective, but, it's essential for her quality of life.
Okay.
You're discussing the plan, and you mention the standard risk that she might need a blood transfusion. The patient, who is a Jehovah's Witness, politely but really firmly says no to any blood products.
A classic situation.
Exactly, but then her son pulls you aside and says, "Look, doctor, she's old-fashioned. Just tell her it's necessary, she'll agree, you have to convince her."
And that is the perfect storm, isn't it? You've got patient autonomy, clinical need, safety, and family pressure all crashing into each other. So our mission today is to break down the UK guidelines, GMC, NICE-E, the Accessible Information Standard, into really clear, actionable steps.
So you know exactly what to do to score maximum points.
Precisely.
So if we had to boil all of that down, all the resources, into one single core truth for the exam, what's the mindset?
The one-sentence takeaway is this. The safest doctor is curious, not judgmental.
Curious, not judgmental. I like that.
Your first job isn't to fix the problem. It's to explore the belief, support the patient's understanding with official help, and then agree a safe, lawful plan with alternatives. And of course, document everything meticulously.
That distinction is so powerful, it really grounds the whole interaction in respect, doesn't it? So why does the SJT focus so heavily on this area?
Well, it's just fundamental to modern healthcare. The GMC demands that we treat patients without discrimination.
Right.
And that means we have to adapt how we communicate, how we propose solutions. This isn't just about being nice. It's about upholding the legal framework around equality and, shared decision-making.
So these scenarios are really testing if you can protect autonomy while still holding those safety boundaries.
Exactly. Get it wrong, and you could be looking at a formal complaint or even a legal challenge for coercion or for breaching the Accessible Information Standard.
Okay, let's start with the blueprint then, the foundational principles. What does the GMC say is the fundamental principle here?
The core expectation is what they call co-producing safe care.
Co-producing.
Yeah. You're not there to just impose a plan, but you're also not there to uncritically agree to something dangerous. You have to actively work with the patient's values and beliefs to negotiate a path that is both clinically safe and legally sound.
It's a balancing act.
A real balancing act between respect, equality law, safeguarding duties, and your clinical standards.
You mentioned fairness and respect. What does the GMC actually demand from us in terms of communication? I hear those guideline numbers thrown around, NICE-CG 138, NG 197, but what does that mean in practice?
In practice, it means there's a legal imperative to provide meaningful communication. The idea of respect and fairness means you have to adapt your delivery.
And that's where the Accessible Information Standard comes in, the AIS.
Exactly. It is a legal requirement, not just a courtesy.
Yeah.
It means you must identify any communication needs, language, learning disability, whatever it is, and provide information in a way the patient can actually understand.
I know that in a busy A&E, the default is often to just grab the nearest person who speaks the language, maybe a family member or even worse, a child. Can we talk about the liability we face if we skip that qualified interpreter step?
Oh, that is one of the highest scoring traps in the exam. Using family or children to interpret, except in the most immediate life-threatening emergency, is just unsafe and unethical.
Why specifically?
Well, clinically, you risk catastrophic inaccuracy, misunderstandings of risk, invalid consent. And legally, the patient's capacity and consent become highly questionable. You're breaching the AIS.
So the safest doctor does what?
The safest doctor insists on using a qualified professional interpreter, someone who gets the medical terminology and can be impartial. That support is the absolute legal and clinical bridge.
That's so crucial. So the patient is speaking directly to the clinician with the professional as the bridge. What about our own beliefs? What if a patient asks for something that conflicts with my personal values?
The GMC guidance on personal beliefs in medical practice is incredibly clear. You must never impose your beliefs on a patient. And crucially, you cannot deny patient access to appropriate lawful services.
So you can't just refuse.
You can't just walk away.
Yeah.
If you have a conscientious objection, you are required to manage that conflict lawfully. That means arranging a timely, safe onward referral or transfer of care. Continuity has to be maintained.
Okay. And one last thing before we get to the action steps. Are there any cultural practices that are absolute non-negotiables, where the law just overrides respect?
Absolutely. Safeguarding is always paramount. Always. If a belief or a cultural practice raises a risk of significant harm, we're talking about things like FGM or honor-based abuse, you have to follow local safeguarding policies immediately.
So respect for culture has a hard stop.
It does. It does not extend to practices that cause harm. You have to explain the limits of confidentiality and document your lawful reason for sharing that information.
Okay, that gives us the principles. Now let's get practical. The SJT rewards a really clear, consistent, safe sequence of actions. What's the framework we should be using?
We break it down into 5 clear, actionable steps. This should anchor your response in any of these scenarios.
Okay, lay it out for us.
Action 1, explore first. This is the curiosity step. You have to ask open questions, things like, what matters to you about this specific plan? Or who else is involved in making this decision with you?
So you really need to understand the beliefs, the constraints, everything.
Everything, before you do anything else.
Oh wait, if I'm under pressure, shouldn't I just skip that and jump straight to offering the safest alternative? Action 3.
And that is exactly the trap.
Uh,
If you skip exploration, you're just making an assumption. You're bypassing shared decision-making, and you risk proposing solutions the patient just dismisses because you haven't understood the core value behind their refusal. Exploration is non-negotiable.
okay, point taken. Explore first. What's next?
Action 2. Support understanding. This is where the AIS comes in properly. Arrange that qualified interpreter or communication support. Use teach-back methods. Can you tell me in your own words what we just discussed? Just to confirm they've understood the diagnosis, the risks, the options.
So the communication bridge is built. Then what?
Action 3. Co-produce a safe plan. Now you offer reasonable clinical alternatives that respect their beliefs where possible.
So for our hip replacement patient,
You'd be discussing blood-sparing surgical techniques, preoperative optimization, high-dose iron. But you also have to be very clear about any legal or safety non-negotiables.
and what if that discussion makes you suspect, the patient's being pressured by the family, or there's harm involved?
That triggers Action 4, safeguard and escalate. If you suspect coercion, abuse, or any risk of significant harm, you must escalate. Senior colleague, local safeguarding team, and you may need to share information lawfully. Your duty of care and the law override confidentiality when serious harm is on the table.
And finally, the paperwork.
Yes. Action 5. Document and follow-up. Record who was there, what was discussed, the specific alternatives offered, the patient's wishes, your assessment of capacity or coercion, the whole thing. Traceable notes are your absolute defense.
Those 5 steps are the roadmap. To make them stick under pressure, though, we need memory aids. I know the sources have a couple of really good mnemonics.
They do. The first is a process reminder. Culture. So, curious first. Use interpret R's, law safety clear, tailor options, understand values, record, and escalate if there's a risk.
Culture. That's good. And the second one, which sort of frames the whole interaction, is respect.
That's it. Report first, explore beliefs, support understanding, propose safe options, ethics and law, consent and capacity, and finally, traceable notes. If you can mentally walk through that respect framework, you'll cover all the SJT criteria.
I love the visual cue that goes with this. When you're with a patient who has a communication need, you should imagine a dialogue bubble between you two. And you place a clear interpreter icon right in the middle. If that icon is missing, your whole process is legally vulnerable.
That's a perfect way to picture it. And we can also think about some practical phrases. You need to sound like the doctor who follows this framework.
Okay, so what should we be saying to the son in our original scenario? The one who wants us to convince his mother.
You could say something like, I appreciate your concern, but my priority is ensuring your mother understands her options directly. We will use a qualified interpreter to achieve that safe, shared decision.
Firm but respectful. I like it. And how do we start the conversation with the patient herself, reflecting that explore first step?
Something like, I want to understand your beliefs about blood products so we can plan safely together and make sure our alternatives align with your values.
And when you're presenting the risks,
You could say, here are the risks of proceeding without a transfusion option, but also, Here are the alternatives, like blood-sparing techniques. Let's see which options help us get a positive outcome while respecting your convictions.
Okay, so here's where it gets really interesting. The scenario patterns. The MSRA uses these common setups to test these boundaries.
Yes, and the scoring logic always rewards the path that combines curiosity and adjustment with firmly upheld legal and safety boundaries.
So let's break down the two most common patterns. Pattern 1. The patient refusing life-saving care, like our blood product example. What's actually being tested there?
It's the balance between respecting absolute autonomy versus the duty of beneficence, doing good. We want to save the patient, but we can't violate their rights.
Right.
So the best action has to include a thorough assessment of the patient's capacity. If the patient has capacity, they have the legal right to refuse treatment, even if we think that refusal is unwise.
What do?
You discuss all the material risks, you involve senior colleagues to confirm the capacity assessment and the alternatives, and you document that decision very clearly. The low-scoring action is to just proceed because you think they're being irrational.
Or the opposite, just refusing to treat them at all out of frustration.
Exactly.
Okay, and pattern 2. The classic family coercion scenario. Relatives speaking over a patient or insisting they make the decision.
This one tests your duty to uphold autonomy, confidentiality, and those professional communication standards, the AIS. The SJT rewards immediate professional intervention here.
So you have to step in.
You have to step in, firmly but politely. Thank you for your support. I must now speak directly with the patient through our qualified interpreter. You have to assess for coercion. Is the patient making this decision freely? And you document that assessment.
So what are the immediate red flags, the things that tell you to stop discussing and start escalating?
There are 4 critical warnings. First, family speaking over the patient, especially if they dismiss the patient's attempts to speak. That needs an immediate professional interpreter and a private chat with the patient.
Okay, what's second?
Second, using relatives or children to interpret. That's a breach of AIS. It compromises consent. It's a huge red flag. Third, beliefs being used to justify harm. Any hint of FGM, honor abuse, severe neglect, that's an immediate safeguarding escalation.
And the last one?
And fourth, refusal by the team to consider reasonable adjustments. That's an institutional breach of the AIS. You have to challenge that.
Right, let's dissect the traps. The low-scoring options designed to tempt you when you're tired, why do they fail?
They usually appeal to a desire for efficiency or for harmony, but they violate core legal duties.
Okay, trap 1. Let the eldest relative decide for the capacitated adult patient.
Fails because it completely sidelines patient autonomy. In the UK, decision-making is individual. Even with a supportive family, it just massively increases the risk of coercion.
Trap 2. Use the patient's child to interpret.
Fails because it compromises accuracy, it breaches the AIS, and it puts a huge unfair burden on a child. Any consent you get from that is unsafe.
Trap 3. Impose your view and proceed, citing clinical necessity.
That's just pure paternalism. It destroys trust, it ignores GMC guidance, and it's a direct path to a formal complaint.
Trap 4. Agree to anything for the sake of harmony, even if it compromises safety.
That's a failure of your duty of care. Colluding with risk just to avoid conflict is unprofessional. Your job is to co-produce a safe plan, not just a harmonious one.
And the final trap. Avoid the discussion or just refer the patient elsewhere immediately because it's too complex.
This is a big one. It often delays essential care, and it's a failure to meet your professional responsibility. Unless you have a genuine conscientious objection, you have to manage the complexity yourself.
Okay, time for the quickfire drill. Rapid questions, rapid high-scoring actions.
Let's do it.
If a family insists on speaking for a capacitated adult, even after you've arranged an interpreter.
Politely reinforce professional boundaries, address the patient directly, confirm their wishes privately, and document your assessment for coercion and autonomy.
If a patient with full capacity refuses treatment for religious reasons, and there are no immediate life-saving alternatives,
respect the decision. After you've thoroughly discussed all the risks and alternatives, get the refusal documented and signed if you can, and you don't abandon the patient.
if a colleague expresses discriminatory views towards a patient's cultural practice,
Address it professionally. Refer to GMC standards on fairness and non-discrimination. Escalate to a senior if the behavior continues or impacts care.
if you have to share information that violates confidentiality to initiate immediate safeguarding for a vulnerable adult,
You explain the limits of confidentiality to the patient. if it's safe to do so. You share the minimum necessary information only when there is an immediate risk of significant harm, and you record the lawful basis for doing so. Precisely.
This has been so clear. So what are the 3 core takeaways a clinician must remember walking into the exam?
Okay, first, every single situation requires curiosity first, assumptions last. Elicit beliefs and values before you even think about proposing solutions.
Right.
Second, always remember the legal requirement. A qualified interpreter or AI support beats family translation every single time, unless it's a genuine, documented life or death emergency.
And third,
And third, you must respect beliefs, but only within strict legal and safety limits. Your duty of care and safeguarding policies are completely non-negotiable boundaries.
so remember the word respect. Your ability to integrate all these elements, from building rapport all the way to ensuring traceable notes, that's what defines a safe, effective, modern clinician in the UK. Mastering this balance is key.
And for more structured materials, scenario practice, and exam-focused guidance that really breaks down the why behind SJT scoring, you can find more high-yield resources on passthemsra.com.
We wish you the very best in your preparation. We'll see you next time for the next deep dive.